everyone here this morning for what hopefully will be a really interesting and engaging conversation. Thank you for coming out here to MHA, and thank you to MHA for hosting us and for allowing us to use this beautiful space for today's event. Want to just recognize a few people in the room who helped make today possible. There's a lot of HPC staffers here. I won't mention all of them, but do want to recognize Deputy Executive Director Colleen Elstemeyer, who's here, as well as Katie Shea Barrett, who is the Director of Care Delivery Transformation and Strategy, and Kathleen Connolly, our Director of Strategic Investment, and all of our wonderful staff here with the Navy lanyards that say HPC. They're very friendly. Come introduce yourself to them, and all of them have put a tremendous amount of work into planning today's event and in helping to support the topic that we're here to talk about today, which is telehealth for behavioral healthcare integration in primary care. I would just say, in terms of a little bit of background, the Health Policy Commission was established 5 years ago, really with the mission of improving the quality of care and access in the Commonwealth while reducing healthcare costs. And the issue of access to behavioral health care became one of our central areas of focus really right away. I think in our first cost trends report, we did an analysis looking at the additional spending associated with patients who had chronic care disease, a chronic care condition, and a behavioral health condition, 7 times greater spending. Much of that spending occurring in the emergency department and in hospital inpatient settings. And so we saw that, and the data indicated to us an opportunity to shift some of those resources and care further upstream and moving some of that money and care and attention for patients, not in the ED, not in a crisis, not in the hospital, but into other more appropriate community settings, including primary care. And so this became a focus for us as we thought about our cost trends work and our research work, our care delivery work. We developed a patient-centered medical home program that was very specifically focused on integrating and enhancing behavioral health capabilities in primary care. A few years ago, we're really blessed and honored to have the legislature provide us some direction around seeing ways that we could use telemedicine to address some of these particular issues. And they gave us actually a lot of latitude to design what exactly we wanted to do with some of the pilot money attached to this program. And so as a board and as a commission, we decided to really focus these dollars on ways to enhance telebehavioral health and thinking about using technology to connect services and supports to clinicians and patients in many different settings. And so we'll hear from some people today who have been working with us on that project, as well as many others who have been leaders in the community advancing this forward, and hope to have a conversation today about what works, what some of those barriers are to scale and expand this, and how policy can be adapted to really support and drive the acceleration of these models. With that, as just a few brief opening remarks, I'm going to turn it over to one of our commissioners at the Health Policy Commission, Marty Cohen. Commissioner Cohen is our official behavioral health designee. Every one of our commissioners has a certain in law expertise that they are required to fill, and the Attorney General first chose a very distinguished person to fill this spot, Mary Lou Sutters, who then went on to become the secretary, and in refilling the spot found another incredibly talented expert to help contribute to the work of the HPC in behavioral health, and Marty Cohen. So Marty's going to help lead today's discussion, so I'm going to turn it over to him. Thank you, Marty. And thank you all for being here.
Good morning. I want to, on behalf of my fellow commissioners, welcome you and thank you for the work that you do every day. I also want to thank the HPC staff. They do a tremendous job in terms of all of the investments and the training and technical assistance that the commission is able to provide. As David said, I'm the behavioral health advocate on the commission. It's about, I think I start my 4th year this month, and it's been a great experience for me, a great learning exercise. One thing I realize is that I should have paid much more attention to those economics classes as an undergraduate. But my background is actually in behavioral health. I'm a social worker by training, and I spent 30 years working on mental health policy, both here in Massachusetts and across the country. And I'm very proud to say the systems of care that have been developed over that time show great promise and great improvement in the delivery of care. But we also have many challenges, and access to care, as David said, continues to be one of them. Where I work in Framingham, it's about a 12-week wait for an outpatient appointment. And if you think about that, if you think about people who don't speak English, people who are looking for clinicians with the same color skin that they may have, if you're looking for specialists in certain areas of behavioral health like child psychiatry, the wait can even be longer. And if you're a young person, if you're a child, if you're an adolescent, a 12-week wait is a lifetime. And I think the hope and promise to solve that access problem actually rests here in this room. I think there are 2 fundamental areas where that hold great promise. One is the true integration of behavioral health with primary care, and we see that through the patient-centered medical home model as a great example of that. And the second is how we use technology, and particularly telehealth. I think, you know, if we can harness these 2 ideas and really in a way that strengthens our field, that provides real integration, I think making access to care, to behavioral health care easier is on the horizon, and I know all of you are working on that goal, and so I'm looking forward to hearing from our experts today. My real duty this morning is to introduce the moderator for today. It's Jean Glossa, who is both an MD and holds an MBA. She is the managing principal for clinical services at Health Management Associates in Washington, D.C. I'm not going to read her full bio for the sake of time, but it's very impressive. Dr. Glossa is an experienced physician and business leader focused on improving access to health care for underserved and low-income populations. She has a broad background of experience in a variety of practices, including the safety net, public health departments, migrant clinics, managed care, medical education, and private practice. And I was talking with Jean a little bit earlier, and she can also tell you where to get the best pie in Alaska. And I'll let her follow up with that. Jean, welcome.
Thank you. All right, thank you. Thank you for that introduction, and good morning, everyone. Yes, I'm from the Washington, D.C. office of HMA, and my colleagues here with HMA told me all these horrible things about the weather, but I just can't believe it. I have to think it's like this every day. So thank you very much for the sunshine and the warm weather. I bundled up for the Boston weather to make my long trek across the parking lot from the Residence Inn, only to find out that I really didn't. So I'm an internal medicine physician. I've been with HMA for about 3 years, and I made a bit of a career change years ago, and a lot of that was based on I'm a military spouse, and so home was where the military sent me. And through that, I realized that the military doesn't always send you to the most glamorous places, and as much as Alaska sounds a lot like a lot of fun for a cruise, they do have very good pie. It put me in a position to be able to provide medical care really on my own. And so I was an MD and I'm an internist, but in Alaska, on a little island, didn't matter. You were the doctor, and whether or not it was a woman in labor or a kid with a head injury or whatever it was, it didn't matter. I was Martha Quinn, medicine woman, but they wanted state-of-the-art medicine provided in an area where it's just impossible. So where I could use telemedicine, I certainly did, but I think from that experience I mostly learned how valuable something could be that I didn't have. So every place I went after that, I thought, why aren't we doing this? This is so easy. It just can't be that difficult. But as many of you on the panel will talk about, and those of you here will say it can be really difficult, and sometimes it's for really good reasons, and sometimes it's for ridiculous reasons, like why is this so difficult? We should be able to do this. So my work as a physician in a consulting firm that mostly works around policy has really been to see where we can push the needle on this, so that where we have policy people who put up barriers, or even when they don't, it's good to have a clinician at the table to say, you know what, we really can provide health care this way, and we can do it just as good as an in-person visit. So I really commend all of you at the Health Policy Commission and really in the state. At HMA, I have the opportunity to work in a number of different states around telehealth, and it's just really exciting to see this level of energy and funding and excitement, and the fact that everyone's here. This is really great. You're really doing what you should do, even if particular things aren't reimbursable, certain things aren't in place yet. You're still foraging ahead, saying this is the right thing to do, this is the right way to get care out there. So I really commend you for that, and I appreciate the opportunity to be part of this. So on our panel today, we have 3 different sites represented that are doing telehealth in some form. I'm going to make a couple opening comments first, and then I'm going to turn it over to our panelists, because I think you want to hear directly from them about what they've set up and what they've been able to do. So we have Dr. Yagman and Susan Benchman from Yagman Pediatrics, Dr. Jonas Bromberg from PPOC, which is Pediatric Physicians Organization at Children's, which probably a lot of you already know that, and Daniel Hoagman from Codman Square Health Center. So I just want to do a little bit of level setting for just a moment. I know many of you that are in the telehealth space are very familiar with these terms, but I never want to make any assumptions. So let's just start for a minute and talk about what is telehealth and what is digital health, and where are these words being used and how they're being used. So telemedicine and telehealth are used interchangeably. There's no real definition, but there's some general consensus as to how these words are used. So telehealth would be the most general. You're dealing with health care, not necessarily a medical visit. It could be preventative care. It's the most broadest term. Even some teleeducation would fall under the umbrella of telehealth. Telemedicine is used a little bit more when you're actually dealing with a patient and a medical issue. You're having a virtual visit. People would consider that telemedicine, not so much telehealth. Most of the time it doesn't matter. It's personal choice. People decide how to use those words, what to call their programs. But in a state like Texas, they have different definitions, and then their coverage guidelines are defined by telemedicine. You can do telemedicine here and telehealth here. Different providers can do telemedicine, but not telehealth. So be careful when you use them interchangeably, and decide if you're in an environment where they are interchangeable or they're not. Some of the other topics, mHealth in the middle here. The M is for mobile health. HIMSS, the large digital health group, organization, they broke off a whole side of their organization into mHealth. Really about a lot of that will be apps on your phone and different platforms that your patients can use to record their own health, as well as send it in to a nurse or a provider to interpret and give them feedback on. That would be the same for mobile apps. E-consult and store and forward, there's some similarity there. Store and forward means it's not happening live. The interaction between the provider and the patient is not happening at the same time. It's also called asynchronous. The best way to think of, a best example of that is like digital retinal scans, where you'll have a van go around and take all the pictures of a patient's retina, screening for retinopathy and for diabetics, and then a physician looks at it at a later date. Technically, that's store and forward. Now, radiology is a great example of that. We've been doing that forever. We never called that telemedicine or store and forward, but that's the idea, is that you've got medical information on a particular patient in an electronic format, and someone's going to interpret that later. That's store and forward. One of the more edgier areas of store and forward right now are telepsychiatry visits, where say a social worker or someone else skilled in how to interview a patient will do a format of an interview of a patient, and a psychiatrist might review it later. And they're actually doing store and forward telepsychiatry visits that way, or assessments. Direct to consumer, that's a lot of what we talk about, things like Teledoc and American Well. These are commercially based platforms that a lot of managed care organizations have bought into or they've contracted with, so their members can dial in. So you're home with a baby with a fever and you think, gee, should I go to the ER? This is really an ambulatory sensitive condition. I don't need an ER visit, but it's 9 o'clock at night and I have to work tomorrow. While the managed care companies are thinking, well, we'll just give you access to a physician over the phone. It sounds really glamorous. I could give a whole talk on the pluses and minuses of direct-to-consumer. There are some significant minuses. As much as it looks good, there's some significant drawbacks that you should consider if you are going to go down that route. Telehealth virtual visit, the one in the middle there, I think that's what most of us consider telehealth right now, and a lot of what the practices on the panel and other ones around the state are doing. That's probably the more traditional definition of telemedicine. Project Echo is an absolutely wonderful, exciting model. How many people in the room have heard of Project Echo? Okay, great. Well, we have 2 people on the panel today, actually, that are familiar with Echo, so you'll hear more about that. Project Echo itself, if you call the University of New Mexico and talk to Dr. Aurora, who's the champion of that, he'll tell you they're not telemedicine. They're technically not telemedicine. They don't necessarily want to be under that umbrella. But if you're thinking about providing health care for a particular patient over a virtual platform, they are part of telemedicine, and it's to their benefit, I think, to include them in all of this because it's really an exciting platform. And remote patient monitoring, the last one that I'll touch on in terms of terminology, probably the most useful and maybe the only evidence-based one at this point is remote patient monitoring for patients that have been discharged from the hospital with congestive heart failure. So they're at home, you don't want a readmission for CHF, right? So a patient will get up every morning and take their blood pressure and their weight, and they just step on the scale, and it's all these just beautiful technology. The patient really doesn't have to be able to do anything other than literally stand on the scale, and by Bluetooth it goes up to their physician or to some intermediary that screens it all. And so you don't have to wait till the patient is 10 pounds overweight and goes back to the ER with shortness of breath. You could be tracking their weight from their home, and then they're up 2 or 3 pounds, and someone calls them, and maybe you can keep them from continuing to gain weight and going back to the hospital. That's one of the few remote patient monitoring use cases that's actually been evidence-based. Okay, so now we're all on the same page here with some of the terminology. And just a couple other points here that I want to make is, why are we all here? What is this telehealth drive all about? And some of it did start with a provider shortage. I didn't have enough doctors in Alaska. Certainly we're not going to solve the shortage of psychiatrists by just making more psychiatrists. We have to be able to use them more innovatively, and one of those is telebehavioral health. Another big push in this area are the millennials, and I'll tell you, I've got 2 college-age daughters. They send me pictures of their rashes. I have a daughter right now in London. I'm not kidding, I just came back from visiting her, and she sends me pictures of her rash. What am I going to do? But this is how this generation wants healthcare. They don't think they should have to go make an appointment on Tuesday and sit in a doctor's office for something that they can do by phone. And it's funny, they're not as worried about their security as everybody else is. My daughter says, anyone wants to look at my rash can look at it, and if they can help me decide what it is, bring it on. They're not as concerned about privacy with that kind of stuff, and that's how they do their banking, their shopping, education, all of it. They don't understand why they can't get healthcare that way. So that's a big drive here that we're going to see more and more of. Payment reform. I think that's an opportunity here as we get away from fee-for-service and into different models of care where providers and payers are accountable for the outcomes, and it's not down to the transaction of who's paying for that particular transaction. It's more about who's paying to keep that patient healthy and what's the best way to do it. As we move towards payment reform, that's where telemedicine is going to explode. And I think you're familiar with a lot of the other ones on here. Now the barriers, you'll see the first barrier is the same as one that was on the other slide. It's payment. It's taking time, but I will try to encourage all of you that across the country it's moving. And when the floodgates open and all of a sudden we're allowed to pay or we're allowed to bill for a lot more of these things and there are more reimbursable services, those areas where they put models in place and they've become good at it are going to be ready to go way before everyone else can. And we've definitely seen where there's been opportunities to do telehealth, and the payments there, they get a large grant, or they get free equipment, or whatever it is they get, and they move ahead and they figure out it's not all that easy, that there's a lot to figure out. So it isn't just a matter of holding back until we can get paid for it. Getting paid for it is necessary, but it's not the only thing you need. You've got all that buy-in and all those things that the people on the panel are going to talk about today. So getting in place for that, because it is coming. Hang in there. Aging providers and aging patients. Aging at home is a big deal. It's expensive, and as the population ages, we need to be able to provide more of this care in the home setting, and doing that by telemedicine and remote patient monitoring and all of those things is really what's going to allow us to take care of the aging population. Okay, so I think I'm going to hold there for a minute. I have a few other things to talk about, but I think you really want to hear from our panelists. So what I've asked all of them to do is spend 5 to 7 minutes each and really give you an understanding of what they're doing in their practices right now. So I think we're going to start with Dr. Yagman and Susan from Yagman Pediatrics.
So I think I'll just up here. I want to thank the Health Policy Commission, because I think they're real support and leadership in.
Yeah, I don't think that might sound.
No, it's not on.
Oh, now it's on. Can you hear me now?
Yeah.
Good. Okay, great. I really want to thank the Health Policy Commission, because I think their leadership and support of behavioral health integration in primary care and behavioral health prime has been a wonderful step up in leadership. And I want to back up and talk about pediatric care, because I think the transformation of pediatric care and the future of pediatric care is really all about behavioral health. If you look at the top 10 reasons for pediatric office visits, we've done really well with immunizations and managing infections, and the reasons for office visits are now almost predominantly behavioral health concerns, and particularly the comorbidity of behavioral health concerns with children with chronic illnesses. And the old model of referral to subspecialists just is not a viable model for pediatric care. The second issue I want to come back to is the opportunities as we move forward for primary prevention. And we are doing a lot of work at the Academy of Pediatrics at looking at buffers to adverse experiences and trauma and toxic stress around resilience. And the hallmark of what I think pediatricians really need to grapple with is how to support relationships in primary care and in the broader community. Developing skills, supporting relationships, and mitigating stress. So that, I think, is a big part of this. And that is all a segue into telehealth. So I think that telehealth or telemedicine has to, I think, start with a different mindset in pediatric offices about behavioral health to begin with. So we were lucky enough with some grant funding about 4 or 5 years ago to bring on Susan, who you'll hear from in a minute, as a full-time social worker in our private practice in Cambridge at Mount Auburn. And it was transformational in terms of patient satisfaction, patient experience, quality outcomes, and cost, to put it mildly, $700 per member per month in cost savings. And we published that paper about 6 months ago. But more important, it changed the provider experience. And the providers were so, the other pediatricians in my office were so positive that when the grant went away, people were unanimous in saying, we need to keep Susan sustainable regardless of fee-for-service payments, and we will take a cut in our salaries if necessary to keep her going. So I think that is, we can talk more about the challenges with sustainability, but I think the starting point for all of this is to transform practices around the importance of integrated behavioral health and the importance of relationships. And I think that to just introduce telehealth or telemedicine around behavior without that framework, without that philosophical background, I would argue would probably be a very uphill battle. I'm going to let Susan talk more in detail about how the challenges in implementing this, but we're just starting to use telebehavioral health superimposed on the model that we already have. I just want to make another point outside the realm of behavioral health. I think one of the challenges for pediatric practices now are the prevalence of retail clinics and minor illnesses. And I would argue that behavioral medicine, telemedicine, provides an alternative to retail clinics that pediatric practices can incorporate, which will really improve quality of care by incorporating everything within the medical home. It will prevent, we have documentation about adverse drug reactions for kids prescribed drugs they're allergic to, because retail clinics may not have access to medication histories. Legions of examples where the benefits of telemedicine incorporated into the medical home for all of this will lead to improved patient care. So I want to turn it over to Susan. We can talk more about the logistics of how we got started with telebehavioral health. But I want to, we've had a couple of experiences, and I'll let Susan talk to that.
Can you hear me? Is this on? And I apologize for my voice. I'm actually just getting over a bit of a bug, so apologize for any coughing. So yes, as Dr. Yagman stated, I was hired about 4 or 5 years ago, and as a full-time physician, part of my work is seeing patients for short-term therapy in the office, and then also being available for warm handoffs from the doctors after well visits or sick visits or anything like that. And then part of my position has kind of changed, where I do some consultation to some other practices as well for care coordination. But a lot of the focus has been on patient care and making sure that folks are hooked in and getting the services that they need. And telehealth felt like a next logical step for us in helping people access the care that they need. And we have, we're at the very beginning stages of that, working with one patient right at this time, just kind of trying it out, but it's feeling like a good fit so far. Sure. So for this, it was actually we. Oh, sure. So your question was.
So actually, so where my question is coming from is that I've been doing behavioral health integration as a clinical social worker for like 9 years, and what I'm curious about is that in relation to that, there's a lot of phone work. So I'm really curious and interested in hearing, because I have a program that we're covering many clinics, one person, and so I would love to hear what, and so they're doing a lot of telephone stuff. So I'm trying to figure out what is that was different before you considered it telehealth, and what is it that you're actually doing that you consider telehealth. Because as a social worker, I sort of think phone work is kind of like what you do, and your interventions are a lot done over the phone. So I'm just really curious what the difference is in terms of viewing it as telehealth. that would just be so helpful to me.
Yeah, I think you described to me on the call, you just look like where is the patient and who's with the patient and how the visits are set up, kind of the logistics of how that visit works.
Yeah, we were looking at this as a visit, as a mental health visit, and so working with the family ahead of time. This was actually a child that I saw previously for therapy, traditional kind of individual 45-minute therapy in the office. Due to the special needs of a sibling of this child, they were unable to make it into the office just due to outside appointments for the other sibling. And so this seemed like a logical kind of workaround to provide this, and due to constraints of travel. And so it's really kind of a 45-minute session that's really kind of done through like a Skype. Yeah, so it's yeah, and it's
done like assessments and stuff.
Right.
But not Skype.
Right. So this is like a FaceTime Skype type of feel. It's not either of those platforms, but I think one of the great things working with kids, and she mentioned earlier, is this is a platform they're very comfortable on. So this is a 10-year-old child who is I think more comfortable communicating with me through this medium than actually being in my office with me. So we're not at this time. So the question was if we're using the platform through our medical record. So actually, Suzanne Mitchell, who we worked with through the HPC HMA, she had suggested DoxyMe as a HIPAA compliant platform that we could use, and it was she had her assistant come in and actually show me how to use it, and it was really quite simple. So we signed up for that.
Can you repeat that? Download because I tried Skype.
Does the patient also have to download, so they have to have certain level of technology and technological savviness to be able to do it?
Yeah, so it's an app actually. So the child is using her iPad, and she was really quite savvy. She's the one that downloaded it. I gave the instructions to the mom, and she was kind of passed it off to her kid. She took a look. She was standing over her shoulder, watching her kind of do all of this. But the little girl set it up herself, and mom helps her sign in, and then she's all set to speak with me.
Yeah, I just want to point out that Suzanne Mitchell from the Health Policy Commission was very helpful in introducing us to DoxyMe, and then we went ahead and clarified all the regulatory issues about encryption and privacy, and testing it out with the child's family before we actually initiated the visit. And I think it's important to emphasize that this was not an initial visit, where I think that face-to-face relationship was critical. So it was a follow-up visit. We ideally have worked with our EMR, Epic, and our hospital network. Ideally, we would like to use a technology called Video, which is automatically integrated into Epic. But there's a cost involved in they're integrating that server into the EMR, and they weren't ready to assume that cost. So this was a kind of interim step, but I think ultimately that's where we'll go. And then, as opposed to copying and pasting the notes of the session into Epic, it'll be integrated from the get-go. So that would be the ideal solution going forward. But I think it's not Skype, it's DoxyMe, and that's important for the regulatory issues.
Yep. A couple comments about vendors and the technology. They are out there like .com. You can go to the American Telemedicine Association meeting, and the vendor hall is football fields of vendors that will give you all of these platforms and toys and all kinds of things. A word of caution to everybody thinking about this. I've seen too many times, and it's sad, where clinics and centers have bought into contracts before they have the clinical model set up, and then they find out later that the vendor or the platform that they just contracted with can't do what they want to do. So contracting with your vendor should be one of the last things that you do, Because if that vendor, if you put your model together what you want and that particular vendor can't do it for you, you just find another one. You should not have to change your model based on, oh, this vendor can integrate with my EMR or it can't. There's so many out there and one's buying up the next one and it's just on and on. So when you have grant money or whatever opportunity you have to do telehealth, going through a very diligent vendor assessment exercise is important. We have lots of tools for that. I'm happy to share those with the Health Policy Commission, and then you can get it from there. Very systematic way, because if you bring a vendor in and say, hey, you know, can you tell me about your product? They're happy to, and they will tell you, they'll give you their nice song and dance, and then when it's over, you think, oh, we forgot to ask about whatever it is. And so there's a nice way to go through it where you're in the driver's seat, and then you can compare your vendors head to head. So looking at vendors is a very long, serious process, and you should really be in the driver's seat for that. Okay, so I'm going to turn over for
I
a
just
second.
want to say one of the advantages of .CME to start with is it's free, so you can work out a lot of the kinks without incurring a lot of cost.
Right, and there are some vendors out there that are free. That are free or very low cost to you, so that's part of your analysis is, you know, why is it free? What is my commitment? What am I getting out of it? So it should be a part of your process that you take very seriously and you spend a lot of time on, because we've seen people get into contracts and situations with vendors that they can't get out of. Okay, so I'm going to pass it now to PPOC if you want to make some comments about your program. Thanks.
So to kick it off, just our program was really aimed at addressing sort of the inadequate access to psychiatric care for children and adolescents. And I'm going to start by just providing a little bit of context about what our organization is and the foundation that we had to launch this telehealth work. The Pediatric Physicians Organization is a statewide network of primary care providers. We have about 500 primary care providers, members that range. We go all the way from Williamstown to Yarmouthport and Nantucket and New Hampshire to Connecticut and Rhode Island. We're truly a statewide network. So geography was important to us in terms of embracing telehealth, given the diverse geography we need to cover across our network. A key partner for us has been the Department of Psychiatry at Children's Hospital, who've been an instrumental and key partner in the foundation of our whole integrated behavioral health program, not just this telepsychiatry initiative. And that foundation is important because beginning in 2013, we really set out to develop an ecosystem of care within our system and not just do a learning community or not just do telehealth, but really build a set of resources that get knit together in a way that supports the transformation of care across our network, and really to make behavioral health as important as medical health in all the practices that, across our network that are already operating as patient-centered medical homes. So as you know, access to child psychiatrists in this state is an enormous problem, especially for those in rural and underserved areas, which are often the poorest areas of our state. Despite the fact that we have roughly 2 times the national average of child psychiatrists, they're not equally distributed across the state. And you know, for those of us that live in the city, you may not realize we live in a very rural state. It's the western part of the state, extremely rural area of the state. And you know, the access is a particular issue out there. And so we believe that telepsychiatry would be a way to fill some of these gaps in access, particularly in these underserved areas. So we have practices that are in Northampton, Holyoke, down on the Cape, up in the Lowell area. So really diverse sort of practices where coming in to see a specialist in Boston is an arduous, expensive task. I mean, there are no psychiatrists on Nantucket, except I guess in August. But not seeing patients. So we were targeting, you know, we didn't expect this to be a way of filling every kind of need, but really for kids it had a level of complexity and the need to see somebody faster than the community, typical sort of community wait time would suffice. And we heard some ideas about how long that wait time is. So we set out, you know, for this targeted population to really try to provide access to care within a 15-day window of that identification and need. And the way we did that structurally was we have telepsychiatrist that sits at our hospital site at 300 Longwood Avenue, and patients come into these offices in their local community, their regular pediatrician offices. They get set up in an exam room that has a small camera type of device in there and a monitor, and they connect with the psychiatrist sitting in Boston for an evaluation. Within 24 hours, the physician, the primary care physician, gets a report from that consulting psychiatrist, and then some consultation follows that to the primary care provider that would either help them manage the patient care on their own in the practice. It could be co-managed with the telepsychiatrist at the hospital, or in some cases, we're able to create a pathway for people to be seen at the hospital. Obviously, that's not ideal for folks living in the Northampton, Holyoke areas, or on Nantucket or the Cape. But if we need to, we can do that. So it's really a starting point to provide direct support, not only to the patient, but to the primary care physician that's managing that care. So that's kind of just basically the sort of what our program looks like, and again, this foundation that's built on it is important. And just to give you a tiny bit more idea about that, it includes a large education component. We delivered almost 50 hours of CME, CE, CEU accredited training focused on integrated behavioral health across the network last year. We provide rapid access to specialty consultation in a number of different ways, and we provide each practice that's integrating with a large amount of consultative support, both on the clinical and business side, to help them sort of integrate mental health into the way they work as a pediatric practice.
Thanks. Can you talk a little bit more at the primary care site where the visit's happening, which is defined as the originating site? That's another term I didn't talk about. There's the distant site and the originating site. And sometimes we think of the distant site as where the patient is so distant, but actually that's not correct. The originating site is where the care originates. That's where the patient is. So at the primary care site, which is the originating site, talk a little bit about, at that primary care practice, what's the impact to them, or what's that like on the day of the visit? Or are they using up an exam room? Is it, who's in the room with the patient? What's that like for the primary care site?
So the patient comes into the practice, checks in like they would for a regular visit. They get roomed, depending on space, sometimes in the exam room, sometimes some other kind of room. I think ideally another kind of room where you're not taking an exam room out of circulation. They're roomed by somebody that helps set up the technology, and it's the first time they've done it, explains to them sort of what to expect and how to use it, and they help establish that connection with the consultant in Boston, and then they, whoever roomed them, leaves, and ideally at the end of the consult, the family sort of met by somebody on the team. They'll kind of debrief with them. Do they understand? Sort of. Do they have questions? Structure, that's what it is.
When I did something similar to this in Virginia with the 3 sites, when the patient came in, sometimes the primary care doctor would say, oh, tell me when that televisit is, because I want to pop in the room and say something to the provider on the other end. Does that ever happen, or have you had any interest in that yet, where the other people on the primary care team say, and then almost make it kind of a team visit, or any kind of discussions like that where they want to know what's going on in there? See that as an opportunity?
I don't know how often that's happening. I think there's I don't know if Jason Nygrosh, who's my colleague in this, may know if we've seen that happening, but we certainly talked about it. I think, and in a way, it's not just the primary care physician. If there's a psychologist or social worker,
right,
that's connected with the care, or medical home person, or somebody, somebody else, in the practice, perhaps, it could be a team kind of thing with the psychiatrist. I mean, we're not putting any sort of limits, and people can sort of be creative with it in those sorts of ways. I think we have a consulting psychiatrist on the other end that, is very comfortable working in this space, and, is flexible and creative.
So we were actually promoting that as a best practice to the participating primary care practices, to have someone come in the last 5 minutes, and it could be the primary care provider, it could be the behavioral health provider. But I think the issue is that it's really hard to sort of manage logistically, and so I don't think it happens very often, even though we think it's a great idea to sort of have that 5-minute debrief. So I would say it usually doesn't happen, but we do have someone who does come in at the end to just talk to the patient, give them the patient satisfaction survey, and sort of wrap it up. But that's the reality of how it usually works.
Yeah, I remember logistically it was difficult, but when it worked out, it was wonderful because you have the primary care provider and the specialist and the patient and maybe a family member all having a video chat at the same time. And I remember logistically when we first started it, the patient came into the primary care site and said, "I have a visit today with Dr. So-and-so," and it was a nephrologist who would rotate around to all of our sites. But that day, the nephrologist was at another site, but that's why we were doing telemedicine to this site. And the front desk said, "Oh no, Dr. So-and-so's at the South County Clinic today." I'm like, I know he's at the South County Clinic, we're going to do a telemedicine visit. And they sent the patient back in their car to drive to the other clinic, and we missed the whole telemedicine visit. So we had a real lesson learned there that you have to make sure everyone, including at the front desk, really understands, because when that patient came in and asked for the visit, they put him in their car and drove him across town.
Yeah,
So that was a lesson learned for us.
I think
for
a
sure.
large amount of the time we spent on the front end was really developing all those workflows and processes for, checking the patient in and rooming them and getting the technology set up and, doing dry runs and making sure there was enough people in the office that knew the equipment and how to use it. And a lot of time spent on that.
Yeah, we learned the hard way on that one. Okay.
Which technology did you use, Jason?
Video.
Video.
Yeah, because of its ability to kind of integrate with it.
Okay, great. So now Dan Hoagman's going to talk about Project Echo. And I think maybe if you take a minute, there are some people in the room that understand Echo, but I think you were going to explain a little bit about what that model is, how it's a little different than the video visits that we've been talking about.
Morning, everyone. So I am the program manager for substance user health services at Covman Square Health Center in Dorchester. We're a federally qualified community health center in kind of the central Dorchester part of Boston. And if you know Dorchester at all, you know it's kind of a mix of sort of parts of the area that have become very high income, and rents have gone up and property values have gone up, but the part that we're in is not one of those areas. It's mainly Black identified or Caribbean immigrant population. We have about 60 churches in a 2-mile radius, so it's a very religious community, which brings a lot of interesting cultural conversations, because the way that we practice medicine and healthcare often has conflicts in that way. So we are constantly kind of learning from our experiences as we provide care for a very much in need community. A couple years ago, we were awarded a grant from HRSA to expand the access to substance use services within primary care. And that's when I joined on the team and began building the service that we have now. And basically what where we're at is our primary sort of service that we offer is medication-assisted treatment, so Suboxone, Vivitrol, medication that's prescribed in the primary care setting to treat substance use disorder as a maintenance or as a sort of, not in a detox sort of form. And then we also provide integrated behavioral health care within primary care that is across the whole health center. We have clinicians available for warm handoffs for behavioral health or substance use concerns that arise among patients that are in for an unrelated visit. And through our service delivery, we began we got more involved with some projects that GE was sponsoring, which allowed us to get access to some grant funding. And part of that grant funding created or had us working with a Project Echo based out of Boston Medical Center, but that spanned multiple sites throughout the U.S. And it was all each team was providing some type of medication-assisted treatment at their site. They were not all primary care centers. Some of them were, psychiatry sites. But it was every Friday or every other Friday we would video conference with one another, and there was a central site that sort of moderated the discussion, and there was a piece that would start off talking about sort of educational stuff, kind of basics of harm reduction and substance use treatment, and then other sort of philosophy of care things. Topics that would come up, and then the second part of each meeting would be case presentations, where we'd be talking about complex cases that we were facing in our practices and sourcing, kind of crowdsourcing ideas on how to potentially manage, these sort of difficult cases. It's a really great tool to be able to not only obviously the learning component and the peer supervision component is incredibly important, but it's also, you get to know the people that you're talking to every other week. You get to, you recognize them, you see them at conferences and, just in the work, and it's like you kind of have more of a relationship because you've, seen and talked to that person, even though it was over video. So, it sort of created, even though it was a virtual community, it still felt more like a real community in a way that our current social media climate doesn't always actually create. This was kind of the opposite example, where it actually did feel like it was kind of bringing us all together as a cohort. So we were fortunate that we were able to use funding to ensure protected time for our staff to be able to attend these WebEcho sessions, and what anymore?
Okay, so a little bit more background on Project ECHO. It started at the University of New Mexico with Dr. Sanjeev Arora, who was a hepatologist. He was treating hepatitis C, and he found these. He had a waiting list of 6 or 9 months for patients to come in from all over New Mexico for their hepatitis C treatment. And he thought, what I'm doing is, he's a very humble guy. He said, this really isn't that difficult. If I could just move knowledge instead of patients, which is their motto, and really support the primary care providers in these rural sites, that they could take care of hepatitis C better, and the patients don't have to make these huge trips in. So they set up this virtual learning community, which is what Dan's talking about, and I participated in it, and I encourage any of you, because University of Mexico is very open. They want everyone to see the great things that they're doing. So you can call them, and you can video in, and you can participate in these. You can watch them. There are some Project ECHOs all over the country that are closed. Academic medical center might make their own Project ECHO community, and it's closed to a certain number of sites. But most of the ones out of University of New Mexico are open. And a couple of us at HMA actually went out there and did their immersion training and learned all the details about how to create one. So being part of it. So when you see it happen, there's the hub site, which is usually the academic medical center, which is what Dan's talking about, where you've got a multidisciplinary panel there, and then each of the sites, each of the primary care sites is encouraged to have as many people on their primary care team participate and listen in. And you do it every week. You want a lot of consistency, and it's very interactive, so that it's not just a grand rounds or a didactic where you're sitting and listening and just information is being pushed out at you. Instead, everyone is encouraged to participate in the discussion, and you'll see over time that they all tend to know one another, and they'll say, "Hey, whatever happened to that patient?" Or, "I heard your daughter got married. How was the wedding?" And you can tell that this is a virtual community of people that have never met in person. But they call in every week, or they video in. That's really the ECHO model. It's not just pushing the information out, but it's really becoming peers and learning. And part of the 90-minute session will be presenting actual cases that are de-identified, or the hub site has the actual data on the patient, but when they're talking about it over the airways, it's de-identified. So you're getting an actual consult on a patient, but then the other half of it will also be more of a update with some slides and some CME about what's the newest and latest and greatest medicine. So most states in some way have Project ECHOs. They usually come out of an academic medical center, but not all. I encourage you all to go at the University of New Mexico website. It talks all about ECHO. You can look in Massachusetts, see exactly where it is. When I was running a network of of indigent primary care clinics in Virginia, you know, Northern Virginia, right outside of DC, has probably the highest density of specialists, particularly cardiologists. But I was taking care of patients who were completely uninsured, and I couldn't get my patients into a cardiologist. It was ridiculous. I could shake a stick and hit a cardiologist, but none of them would see my patients, or very, very few, to be fair. So we would call into University of New Mexico because it was de-identified, because they're not actually practicing medicine on that particular patient. I was able to get a consult on my patients at the University of New Mexico in their Project Echo for cardiology and rheumatology and a couple of things. So you can all do that. If you're dipping your toe in telemedicine and you want to try something like this, it's absolutely a great way to go. So I know Dr. Bromberg, you also have some experience in Project Echo. So if you and Dan can both talk about one of the hurdles we saw about Project Echo was really getting that participation from the primary care site and getting them to step away from their busy practice and call in once a week. So maybe the two of you, with your experience in Echo, can you talk a little bit about that and how you got your primary care providers to the table, and not just the providers, but the whole care team is encouraged to participate. So how did you handle that?
So as I mentioned, we were very fortunate that we had some funding that allowed us to kind of buy some protected time, you know, by spending, you know, sort of securing that time that normally would be paid salary to that staff. We were able to kind of pay for the salary out of the grant, which I think anytime you can get grant funding, it's obviously very helpful. But you know, I think so. The key components I think that contributed to allowing our team to participate. One was provider champion. So having, you know, looking at topic areas that are significant to your patient population and saying, hey, you know, there's a lot of diabetes here, or there's a lot of high blood pressure. There's a lot of substance use, and having someone in the practice who that's their sort of kind of bread and butter, allowing that person to have some flexibility around taking time to be able to do sort of enrichment activities like this. I think that allowed for two of our physicians to be able to free up time because of their interest in that topic specifically. So the champion teams help. And then, as far as having interdisciplinary teams, often, if we're fortunate, you can sort of craft, visit schedules around something like this. So I know when Echo is going to be every week or every 2 weeks. I'm able to, plan in advance to have that time protected so that my clinical staff can attend, because in the long run, the benefits of participating, at least, from what, the evidence has shown, what Echo, has shown is that, we're able to provide better care because we're able to think a little bit outside the health center. One example that I would give is, when talking to some of the other sites, you would realize that things that we sort of knew was part of our core philosophy of care, we just assume that everybody thinks that way, that everyone thinks, harm reduction is, a good best practice. But you started to realize, like, oh wow, there's like lots of sites that, this is very new, and this terminology is very new. So I think for those are the kinds of things that are really beneficial. It's not just what I learn, but it's also what I learn about the community. And so I think having, identifying people on your team or in your practices that are, interested in the topic area and sort of giving them the leeway to kind of explore and have some time to do it. I think that was a big part for us.
But how do you get the people there? I don't have any magic or secret sauce. We use, we're a network of independently owned private practices, and an hour away, affects the bottom line everywhere. So we just use our powers of persuasion and motivation, and I think we deliver a product that delivers value, to the end user, so to speak, and we also have scheduled them at lunchtime, so they don't have to necessarily give up an hour of patient care time. Do them in the middle of the day, 2 times a month, and it's a challenge. And I think if you have a few people that have real positive experience with it, you use them as a champion to sort of put them in front of other people to persuade and motivate. But it's largely about persuasion and motivation, I think, and delivering something that offers value.
Yeah, and in the Project Echoes that I observed, you could tell the providers find value in it, and they make time, and they do it over lunch. You could see a lot of them having lunch, but they have an opportunity to get a consult on their patient. They know the impact that has to that patient to not have to drive to Albuquerque, and at the same time they're learning, and they'll take that learning to the next patient with hepatitis C or whatever the disease state is. So you could see the providers that really found personal value in it, and also most of the Project Echoes are set up where you're getting an hour of CME. So for the providers in very rural areas, that's a lot of value to get that. There are a few models where Project Echo, where there's some funding behind it. One of them is and I'm not sure if they're still doing it, but in New Mexico, Molina Healthcare pays. Well, first of all, the state has mandated, or they did. I don't know if with the new procurement if they're still doing it, but the state has just mandated all the managed care companies just pay into it, just a flat rate. So they had to, if you were providing Medicaid managed care in the state of New Mexico, you just have to pay a certain amount into University of New Mexico for Echo. They just made it a state requirement. And then the second thing Molina did on top of that was for Molina contracted providers throughout the state. If a provider presented a Molina patient, there was no CPT. It wasn't a specifically billable code, but there was some other mechanism where they would submit that to Molina, and Molina would pay them a stipend because Molina knew at the end of the day that was a lot cheaper than schlepping that patient into University of New Mexico, and they knew the care was going to be just as good. So there are some instances where there is some reimbursement for Echo.
Well, in our state, the provider can if the patient has a public insurance, can bill for a consultation. But I don't know that anybody ever has. I don't know that we've had any experience with people.
We do, yeah. There's a CPT code for like you're saying, billing for 15 minutes. I think it's 15-minute blocks of consultation with an outside agency. And so because we were already funded for the time, we weren't doing it for that, but we have done that with other cases in other ways before. So there is the opportunity to explore whether it makes sense to, especially if you're presenting a case, use that as a word, incorporate that into your workflow.
We have a question in the back of the room.
So in that vein, can you speak a little bit to the billing part for using telehealth with direct patient services? And also, I'd be curious about your risk management expertise, having looked at this area in terms of using telehealth with direct patient.
Go ahead.
Yep. So one of the things that took some time in initiating this using telebehavioral health was to clarify the issues about contracting with the patient for a specific consent form, clarifying the malpractice and encryption issues, and I think the major issue is less complicated within a specific state, a little more complicated in terms of licensing issues when one might cross state lines. So that was one issue. The billing issues, I think, are evolving. Medicare has been the leader in billing codes using either a GT or a 9.5 modifier. Some confusion about place of service codes, but basically the typical EM codes with this modifier for telemedicine are certainly widely supported throughout the Commonwealth by Blue Cross. Ken Duckworth has been a major advocate for this. I think Mass Health has been very slow to, we actually had a presentation by somebody from Mass Health at the recent Children's Behavioral Health Advisory Committee, but I don't think they're there yet in the state.
A couple comments about risk management. Oh, go ahead.
I think that, from our end, in terms of billing, I think that just for those in the policy realm here, I think the largest barrier challenge we face is it's just a lack of uniformity in what insurers pay for. It's all over the map. It's very insurer specific, and in all kinds of different ways that, I think folks learn to do it, but there's a large front-end burden of dealing with that lack of uniformity. And some insurers cover full-on parity with an in-office visit, and some provide no coverage, so it's just all over.
One other risk management issue that Susan can speak to, when you're doing telebehavioral health with a child, you do need to make sure that there's an adult present nearby in case there are safety issues.
Yeah, that was one part of the agreement with this family that we started the pilot with, was a bunch of conversations up front with the family about what this would look like, and giving them the informed consent, but then also talking kind of generally about safety and making sure that there was an adult kind of on premises on wherever the child is, and that they would also be available should anything kind of concerning come up during the session. And typically I'll check in with the parent kind of before I meet with the child for telehealth.
So a couple points on risk management. First of all, about licensure, I haven't heard, or I don't think anybody here is thinking about doing telehealth across state lines, but if you were, it's really about, you have to be licensed at the location of where the patient is. Because remember, I said the originating site is where care occurs. So so the provider has to be licensed where the patient is. And so as part of that, you should have in your process that you validate where the patient is. So if the patient is reaching out to you over their smartphone, or the tablet or whatever, you do want a process of asking them where they are. That's the first thing. And then, like I said earlier, there's certain things you need to do first before you talk to a vendor or you sign anything. And one of those is defining that business model and defining those workflows. And as part of those workflows, you want to describe exactly what your scope of practice is. Are you going to do everything that you do in the office? You really have to decide what you're going to do over telehealth and what you're not, and that's really part of your risk management. And what are you going to do when the conversation goes south? What are you going to do when the patient starts with one problem and now they have another problem? What are you going to do about that emergency back line? What are you going to do when the connection fails in the middle of the visit? All of those workflow things, talking through every scenario and having it documented, that's your risk management plan. And then the other thing is you have to talk to your carriers first. Some of them may say, fine, great. They may say, show me a copy of your workflows, whatever. But if you ever were to have a problem, you don't want to be notifying your carrier at that point that you're doing telehealth or telebehavioral health. You want them as a partner all along. So that's really what you want to do, again, before you sign contracts, before you do anything like that. That's all part of your workflow analysis and building your program out. Any other questions on risk management before we move on?
Yeah, I had 3 questions. One is related to that. I don't know if you do any kind of, or have any kind of screening assessment to determine which patients or which kinds of referrals are and are not appropriate for the video virtual visits, and if the virtual visits can take place with patients with suicidal ideation or those that are in crisis. And I also wondered about, I know we have a real problem with pediatric prescribers for psych, and some of our pediatricians are more comfortable than others in managing those meds, and whether these psychiatry folks that do these visits act primarily as consultants, or if they're willing to continue managing the medication for these patients.
So I'll take a first stab at that. We're seeing very few instances where you're using telebehavioral health in a crisis in an outpatient setting, or a patient calling in from home. Usually if it's any kind of crisis and you're dealing with doing a visit over technology, that's not going to be a scheduled visit. I mean, you're really going to have to make your case as to why you needed to do a crisis visit over video. There's really no other option. It really has to be better than nothing. Where we're seeing telebehavioral health used in a crisis is in hospitals, ER to ER, when a patient is on ER hold and they need a psychiatrist and the patient's been sitting there for hours and hours. But in the outpatient setting or any kind of scheduled visits, that's usually not going to be an appropriate visit, or that's not where you're going to start your telebehavioral health program. I'll turn it over to you guys. What do you think?
mean, the ethos kind of within our telepsych program is the same across our integrated care program, and it's actually really consistent with, I think, the ECHO kind of ethos in terms of we want to support people in the primary care and that everybody in whatever role they're in to do a little bit more to push their sort of do whatever they're comfortable doing, but a little bit more in the behavioral health space, make them more capable, more competent. And so that our telepsychiatrist is primarily trying to support the medical home management of the issue, but then can in a tiered sort of set of ways can supplement that where it's very complex and requires a specialist, or where there's less comfort for the person on the other end.
If we didn't answer everything, we'll come back to that. I want to make sure that we talk for a minute about measurement and metrics, and a lot of sustainability has to do with proving as best you can that what you're doing makes a difference. So I'd like to ask all of you, what are you measuring? What do you hope to measure? Are you measuring too much? Do you wish you measured something else? And I'm gonna make it a little bit more difficult and say I'm going to assume you're all measuring satisfaction, and I'm going to assume everybody participating in it, you've got patient satisfaction and provider satisfaction. So aside from satisfaction, what are you measuring to show that what you're doing is making a difference, or what are you thinking about measuring?
So a couple things. So as a health center in general, things that we're measuring related to behavioral health and substance user health is looking at patients that were previously, unengaged with or not engaged with behavioral health, but on waiting lists, looking at how long they were sort of waiting, and then by offering integrated care throughout the health center and trying to increase access in that way, we've seen that number drop significantly, that the number of people that are waiting, because often what we find is that people that are looking for behavioral health, I think the average number of visits for anyone seeking behavioral health is like 2 or 3. Like, it's a fairly low number, because most people will go for a couple of sessions. They have like one thing that they're sort of looking to work on, and then they sort of, do that one thing, and that's something that an integrated care model is excellent for. That's what it's designed for. Short, brief intervention, and then it's much more infrequent that people will continue on for long periods of time, and that's when you would transition that person into more of a specialty behavioral health long-term kind of clinic. So. That's one of the things we're measuring. Other things that we look at is, how are we doing as far as screening our patients? Are we running through the PHQ2 or the PHQ9 if necessary? Are we doing the GAD? Are we doing doing substance use assessments in primary care? And we track all of that and watch as provider engagement increases. The things that we're thinking about measuring, I'm actually very fortunate. I've been starting to work with the Tufts Masters of Public Health program to mentor students that are interested in doing some doing kind of getting some field experience with community health. And so I have one student that I'm working with who's doing sort of her practicum at our site, and we're going to be looking at patients that are currently engaged in our service prior to switching to a more of a nurse-led model, which is currently our nurse is like the hub of our clinic, of our substance user health services, so everything kind of branches out from her. What our patient outcomes were looking like prior to rolling out that model, and since we've rolled out, ER utilization, overdoses, it's sort of comorbidities of substance use and behavioral health sort of incidents. So that is something that she's working on currently and aims to be done by about July. And so I'm really interested to see what kind of results she comes with, because it would be helpful to know how well what we're doing is helping. So.
In terms of our measurement plan, our primary aim again is this target of sort of reducing time from the identification need to when a consult happens. So for the kids that are identified needing this type of consult, we want 75% of those kids at a minimum to get that consult within a 15-day time window. Most of our, given the limited scope of the pilot, most of our Other things we're looking at are sort of more process aims and sort of outcome aims, because we won't have enough data to look at outcomes. But we are looking at the population in terms of is there a shift in ED utilization or other sort of crisis high acuity service or utilization. And then on the process and things like were we able to set up a reliable platform that worked and was bug free, those kinds of process sorts of things.
So, not specifically around telebehavioral health, but around behavioral health more generally. When we set up this project years ago, we did a good search, and we actually had some success using a measure called the Parent Stress Index, looking at pre and post their interventions with Susan, and showed improvements there. Our screening is pretty universal. It visits with specific instruments like the Pediatric Symptom Checklist or the PHQ-9. We developed registries of all of the conditions that Susan was seeing kids for, and tracked those quality outcome measures based on those screens, and showed some improvements there. And finally, we had cost data from our Independent Practice Association from claims, which were largely related to both medications, ER visits, hospitalizations, and that was interesting. So we published this paper about 6 months ago, where we showed some significant cost reductions for the registry group with comorbid complex special health care needs and behavioral health conditions. So those are the metrics that we've focused on.
Okay. I think we have time for some questions.
I know some of you, but I'm John Strass, and I'm responsible for the Massachusetts Child Psychiatry Access Project.
Can you hold on for just a minute until we get you a microphone?
Hi, good morning. I'm John Strass, and I'm responsible for the Massachusetts Child Psychiatry Access Program, which is run through the Department of Mental Health. And I'd really like to compliment everybody on the panel for the services that they're talking about. And I just want to mention, and I hope all of you who are in the pediatric world, unfortunately not, can't help you in the adult world, is that to complement the Learning Collaborative Project Echo type program and the telehealth for when there's access issues for especially consult, the ability in Massachusetts for any primary care provider can get a child psychiatry consultation within 30 minutes on the phone about any problem that they're having, and help with both management and resource and referrals. So I know all these practices are using that service, and I think it's complementary. And from the national perspective, just we now know that about a third of all the kids in the country now have access to a child psychiatry consultation, the primary care providers for their patients. So, and in some states like Oregon, it's really been complemented with the Project Echo process at the same time. So one of the things we know about behavioral health is that there's so many variations that you still have times when you have a question, and it's nice to have that real-time consultation. Some people have tried to do it with e-consults. It's a little harder because it's asynchronous, but as opposed to a telephone consult, which is what we provide here. And so if anyone needs information about that, I'd be glad to help them. Thank you.
Thank you. Any other questions?
When you're doing a telehealth visit with a child that's at a primary care practice, is the child in the room alone the whole time? And if not, do you have like age segments where you require the parents to be there, or how does that work?
Yeah,
a child or an adolescent?
It depends on the age of the kid and their comfort. I mean, and the family's preference, I think. we don't have any kind of rigid guidelines. You know, I think we take a pretty patient-centric sort of approach. I mean, what's the problem? I mean, do we have a benefit from having the parent there? Is the kid, you know, especially as you get into teen years, who has the choice there? You know, so typical sorts of things I think we wrestle with adolescents and sharing visits or not in the pediatrician office.
Okay, thank you.
You know, one of the things that we haven't talked much about, but that our practice is, you know, really working on going forward, is early child mental health. So pediatricians, you know, have very intense contact with parents and children in the first few years, and you know, with John's help and McPath for Moms, we're very focused on identifying and managing mothers and fathers with postpartum depression, and also grappling when we identify behavioral concerns in the 0 to 3 age group with working with preschool programs to prevent preschool expulsion. And I think there's an opportunity for telehealth with preschool programs to consult with preschool teachers, pediatricians, or healthcare consultants to most child care centers, and I think we need to play a more active role in supporting the preschool programs, not just about fever and head lice, but about behavioral health problems in young children.
Thank you, David Seltzer from HPC again. I really appreciated that last comment and just wanted to highlight the state recently had a commission on behavioral health upstream prevention, and a report was recently released and made a lot of recommendations actually around bolstering and supporting mental health services in the primary care, especially in the pediatric settings, understanding, of course, that so many of lifetime mental illness is developed at a young age and throughout childhood and adolescence. And so I think that's going to be a continued focus for the Commonwealth in terms of how to support and provide resources really as far upstream as possible in identifying risk factors and connecting with family and supports and supporting social emotional learning activities. I wanted to make just one quick recognition as well. There is another HPC commissioner who is here, Dr. Chris Kreider, right here, who is our newest HPC board commissioner, who is our primary care physician spot at the Health Policy Commission. So we practice what we preach. We have our behavioral health and our primary care commissioners here today, and I just wanted to recognize you for being here and taking time to participate in this as well. I do have a question for the panel. Every single one of you, I think, identified as one of your key success factors some grant funding and also just great clinical champions. And grant funding can run out and clinical champions can move on and go to other places. How are you thinking about sustaining these models, for the next 5 years?
This is a particularly relevant question for me because so we recently transitioned into the Boston Health Net ACO, so we're an accountable care organization with Boston Medical Center and several other sites, that community health centers and partner sites in the area. And part of that rollout included the expansion of leadership roles at the health center, one of which being we have a medical director now who manages the ACO sort of rollout and oversees kind of issues related to that. And he is also the substance abuse provider champion. So he gets 3 hours of admin time a week. I think he got an extra 2 for his new responsibility. So he has like 5 admin time over what a normal provider would get at full time, which is like desperately not. I mean, this is someone who, he and I will like be conference calling on like Sundays to get work done because it's the only time that he has available. So, I would make a pitch that yes, grant funding runs out. But there's also always new opportunities that, and it's important to have someone, I think, that is able to be looking for new grants, to be working, to be collaborating with other outside organizations, who has sort of a presence in the community that you're trying to treat, because those types of opportunities do come and go, but they come again. And so it's important to be on the lookout. We're currently seeing that the funding that paid for the Web Echo that we participated in, it was sort of a 1-year thing. And so it's, figuring, what we've kind of been thinking about is, what's the value of continuing to do this even when it's not being necessarily paid for? And what we had decided was that we could potentially, we actually found that for Web Echo in particular, it was better when you had smaller groups participating on our end. When we had a big group, if we had 6 or 7 people in the room, which is most of our treatment team for substance use, side conversations with side people would get distracted. It was actually kind of difficult to do. Drop that down to like 2 or 3, and now you have, it's much more intimate, it's more engaging, and you're also able to kind of flex in and out your staff depending on the week to provide everyone access to it, but also to not necessarily, if your concern is not wanting to lose clinical time, then you get to kind of offset some of that. So both are things that happen. I don't know that there's a way, sort of, especially in the community health world. I mean, we don't have necessarily access to, we have to sort of go outside the organization for anything that we're gonna try and do in a new way. And so it's, having to kind of take it as it comes and utilize that value as it's there.
I mean, for us at a system level, it looks like, the people delivering the care, whether they're an integrated telepsychiatrist or a psychologist in a primary care practice, those people usually, can work in a way that they cover the cost of the provider time. It's the people, the infrastructure, or the other people that support the delivery of care across the program and network, where, that aren't generating revenue, that, we have to, I think the burden's on us to demonstrate, a return of value, so that our health system then, invests in that. And I think as mental health people, we need to, so few of us were trained to work in this type of environment, and I think there's a lot of change that as mental health professionals we need to train people and get people to practice differently to function in a primary care environment and in a business sort of way.
I think there's a critical question, and we really have grappled with it since our grant funding ran out 2 or 3 years ago. We tried multiple mechanisms. So one of the things that we tried to do was to bring on a parent partner. A lot of the work in behavioral health is care coordination around behavioral health, which is really quite different than care coordination in other domains. So we brought on a parent partner to do a lot of that and work under Susan's supervision. That was, again, a good model when we had some grant funding, but the care coordination codes are not adequately paid for, and so that wasn't a sustainable model. We then went to, billing behavioral health codes in the fee-for-service model. It looked like the payment models were much better when one was billing under a mental health agency. So we developed a collaboration with a mental health agency, and although the fee-for-service payments were higher, the regulations for paperwork for an initial visit were totally incompatible with the concept of a warm handoff in a pediatric office. So that didn't work. So we've come to 2 relatively good solutions. One is we convinced our independent practice association that at least the care coordination functions were so valuable for all the pediatric practices in the IPA that they are now covering half of Susan's salary to do care coordination throughout the IPA. For the behavioral health fee-for-service billing, based on lots of recommendations through the Academy of Pediatrics, we're now billing behavioral health services just like a nurse practitioner in an office as incident to the physician. And that's been a much more viable model that at least enables us to cover Susan's EMR license.
One other thing I wanted to kind of mention, I had mentioned that we were rolling out sort of our involvement with Accountable Care Organization, and part of that rollout will ultimately be global capitated payment based on risk. And so the idea is that as fee-for-service gets phased out, losing that hour to participate in a learning community actually becomes less of it's not as much of a loss, because I think healthcare is transforming, where we're moving away from the idea where like it's all about the number of visits. We're moving into a model where we're going to be paid a certain amount of money per year per patient depending on their risk. And in something like Echo, I would say allows us to provide better care to keep the cost of treating that patient lower ultimately. Because if I'm able to be effective more quickly because I have good peer supervision, I'm getting ideas from outside my organization, that's going to help me to then have that the idea is that patient care will improve, that patient will go to the ER less, will overdose less, or whatever the medical condition you're treating is, that you're able to effectively treat and prevent those conditions by having this kind of availability.
I'll just point out that we've had a lot of discussions about this. The challenge for pediatrics in ACO value-based care is that the cost savings to the ACO are not or certainly not short-term in pediatrics. It's much more long-term, and so the attention is all going to be on the high-cost adult care. So that's a challenge for us.
So just a couple closing thoughts, because I know that we're actually over time. The discussion about sustainability is so important. It's like when I was a resident, I would teach the medical students, discharge planning starts on the day of admission. Well, you have to think about that the same way with your program. Sustainability thoughts begin when you're putting your program together, because it is disappointing to really put something together that you can't keep going. One other thought about the codes. I heard a comment about the chronic care codes. I also want to put a plug in for the collaborative care code. So those are different. Sometimes people get those all the codes together. I'm not sure about where the state is on the collaborative care codes, but that is exactly the behavioral health that's evidence-based. CMS has approved those CPT codes, and a lot of the behavioral health telemedicine pilots that I've talked to, or projects, not necessarily pilots, have a lot of those elements of collaborative care, and there may be opportunities in the future, I would hope there are, to build those collaborative care codes, which are different than chronic care codes, and could do a whole afternoon on collaborative care. So just a couple other thoughts that I want to leave you with, some resources. I'll leave these 2 slides up. So many of you probably already know about the telehealth resource centers. It's federally funded. There's the National Telehealth Resource Center, and then it's broken up into regions. You're in the Northeast Region Telehealth Resource Center. 2 organizations. CTEL is out of DC. It's a lot of legal regulatory issues around telehealth. It has very little vendor funding, so it tends to be expensive. But you can pull some free stuff off of their web, and you can usually get them on the phone, and they'll answer questions for you if you have legal. But they're very much a legal issue around telehealth. American Telemedicine Association is a trade organization. They're trying to become a little bit more rigid and evidence-based, but clearly it's very, very vendor driven. But there is a lot on their website. Usually, just one person in your organization becomes a member. It'll just open up access to all of the different interest groups, and they are very up to date on the regulations in different states, both the state and federal level. So I would encourage maybe one person in your organization to become a member. There's the Northeast Telehealth Resource Center. The Center for Connected Health Policy is out of California. Most of that is on the web. It's open sourced. You can go in there and follow any kind of legislation. It's a very, very good source. I'm in Virginia, so I'm part of the Mid-Atlantic Telehealth Resource Center. It's close enough to you all. Plus, anything that's on the regional telehealth resource centers, of course, is open to everyone. You don't have to limit yourself just to the Northeast one, and because a lot of that comes from federal funding, it's open source. HIMSS is also another large trade organization. You have to buy into that too. I'd start with ATA, but HIMSS certainly has a large component of telehealth. And like I said, the resource centers are broken up by regions, but California has their own. And there's a lot of great open source stuff on their website too. And then I listed some other resources at the bottom. So I wanted to leave you with that, a couple other places to go get free stuff. So I appreciate the opportunity to facilitate this today, and I think the Health Policy Commission has some closing remarks.
Hi everyone, I'm Kelsey Bregman, and I'm a program manager here at the HPC. I just wanted to take a couple minutes to thank everyone for coming out to this event this morning. As Commissioner Cohen and David Seltz talked about earlier today, supporting behavioral health integration and really highlighting innovations that can build behavioral health capacity is an important priority at the HPC. So thanks, Jean, as well as all the panelists for coming out and sharing your experience with telehealth. And thank you also just to everyone else who came out this morning to help participate in this conversation with us. Really glad to see everyone here. Additionally, I just wanted to leave you with a few thoughts. One is that we are recording this session and hopefully we'll be posting it on the web in the next few days, so I will send out that link for anyone who kind of wants to revisit some of these points that were made. Additionally, for those of you who don't know, this event is part of a broader technical assistance program that the HPC is offering to support primary care practices in building capacity for behavioral health integration. So in addition to offering events like these on different behavioral health topics, we're also offering a individualized practice coaching for primary care practices who commit to applying for our PCMH Prime certification program. So through that, primary care practices can apply for up to 20 hours of individualized practice coaching delivered by HMA staff. So if that's something that anyone is interested in, please talk to me or email the HPC. Practice coaching can be used to support a behavioral health integration project of our practice's choice. So a pretty good opportunity. And then finally, last but not least, we're handing out some evaluations for this event. Would love to hear anyone's feedback to help us craft future events that would be helpful to all of you. So thanks again.